Okay, we're ready to go? Good. So we want to speak about the salivary glands, which I think you all remember. If not, we'll pick up really where we did last time. All right. Now, just wait a second. There we go. We'll see if NYU said this was impossible. I guess not. So I prefer being very mobile, as you can guess. So just to remind you, we have the parotid gland, the sublingual, minor salivary glands. We have submandibular glands, each different, each doing a different composition, each one having a different function. So we're going to go through them and where they're located. So the parotid gland is the largest gland for us, represents predominantly a serous gland. It is about 25% of your salivary secretions. We'll speak about the other 60% being submandibular and then sublingual, which is about 5%. Okay? Now, for the most part, sublingual is mucus. Submandibular is mixed serous and mucus. It has the serous demilunes, and parotid is predominantly a serous gland. You will have to know the ducts. Also that we have minor glands for a lot of reasons. We have the labial glands. Those are both mucus and serous. That makes sense. Buccal, again, mucus and serous. Again, that also makes sense because we want to prepare the food for deglutition. We also want the serous secretion so that we can also clean the oral cavity, we can wash, we can control pH when we get to saliva. We have the palatal glands, we have the lingual glands again. The palatal glands that I'm going to remind you of, especially in the posterior part of the hard palate, I'll show you a diagram of that along with fat pads that are located there, are really posterior third of the hard palate and clearly the soft palate. Okay, whoops. And that's really, now, the minor glands are not found, really essential. They're not found within the gingiva and the anterior hard palate. They're found everywhere else. We spoke about if not, we'll speak again about the glands of Van Ebner. The glands of Van Ebner are serous glands. The serous glands that are in the tongue, really at the base of the circumvallate papillae. All right. So again, part of it, a lot of these other palatine, subpalatine glands are really mucus, as we're going to see. So here is the parotid gland. It has essentially, it's a small part of the saliva. Now, all of you think it's an awful big gland for a small part of the saliva. It plays a very important role in terms of the time of the day in when its secretion comes about. It is serous. It has a lot of fat tissue in it. And I'll show you a picture later on of inflammation. I don't think anyone here has had mumps. Anybody? You ever heard of mumps? No? Okay. Just teasing you because everyone that I grew up with had mumps. And there were even books written. Measles, mumps, and chicken pox were really what every child had. It was really great because I got a lot of gifts. We secretly make amylase and secretory IgA, which I'm going to go over for you. And again, very painful. And that's reason because the facial nerve passes through the tissue. So we got to be very mindful of that particular gland. Now, what we want to take a look at is take a look at the ducts. So what you want to do is the primary duct is Stenson's duct, and you can see there's a small elevation right here. So you'll see that. That's really the opening of the parotid duct on the inner surface of the cheek. It's very, very clear upon examination. And it's for the most part, it is parasympathetic. You remember the parasympathetic system? Did I mention that right? I spoke about SLUD to you. Yes? You've heard the term SLUD? No? What's the difference between sympathetic and parasympathetic? What does that mean? Fight or flight. So, and parasympathetic is what?
Like you're doing it, I like to think about it like you're doing it when you're relaxing or not really thinking about it. So it's something that you gotta do that naturally.
And that's how you organize it? What other courses are you taking now?
Everything.
You're taking A and P now? Yeah? Do I have to go back and change your grade? Okay, just on an exam. So let's do this quickly because you really should know this. When you say fight or flight, what does that mean?
When you're put into a certain situation where your body is endangered, then
So essentially, you're running from a mugger, right? Right? So you hear the footsteps, you hear a mugger, so how does your body respond?
you could have like an increase in heart rate.
You could or you do?
You do.
Okay.
You might sweat.
You might?
You would.
Thank you.
Maybe digest food. I don't know if you digest.
Okay. All right. I'm going to teach you this because this is important because it comes into play. So, fight or flight and parasympathetic, I call it the parasympathetic pig, but some books call it the rest and digest, and it's probably even more important. So you're running from a mugger, right? What do you want to do? When you're running from a mugger, you want to see nearsighted or do you want to see in the distance? You're running down the street. You want to see what's ahead of you, right? Correct? So your pupils constrict so you can see in the distance. Where do you want blood flow to go? You took the heart. You have an exam, right? On the heart. Where do you want blood flow to go? To where? Maybe to your muscles. So what do you want to do? If you don't send it to the muscles, right, what's going to happen? Then you're not running from a mugger, right? Do you want blood flow to go to the skin? You do? I don't think so. Have you ever run and fallen? When you run from a mugger, what you're telling me is that you're going to die when you're running from a mugger. The skin is the largest tissue in the body, right? So when you're running from a mugger, you want the blood flow to go to the muscles. Where don't you want it to go? You don't want it to go to the skin because when you're running from a mugger, right, if you fall down, you won't see any bleeding. You get up, you go, and you finally come to a rest, and you see the blood pouring down your leg. You have constriction there. When you're running from a mug, when you're running for a bus, when you're running for a train, everything is great. When you stop, don't you feel hot and really sweaty all of a sudden? That sweat pours down from you, you feel really hot. That's because you constrict blood flow from going to the skin, right? You send all the blood to the muscles. We call that the splanchnic shift. Okay? That's really, we're shifting blood flow to the muscles from the GI tract. When you're running from a mugger, do you want to digest the food that you've eaten? No. Right? So do you want blood flow to go to the stomach? No. Good thing. When you're running from a mugger, do you tell the mugger, excuse me, you got to stop? Hey, stop, I got to pee. Stop, you pee, do you do that? No, you don't. You say, wait a minute, mugger, stop, I got to poop. My daughter-in-law is a GI, a gastrointestinal physician. We live on poop, right? You don't want to. You don't want to stop pee. You don't want to poop. You don't want to. Right? You don't want to do any of that. You want blood. You want to see in the distance. When you stop, right? You dilate your bronchi to increase the amount of oxygen you get. You constrict blood. You want some blood to go to the muscles because you're really in oxygen debt, but you shift the blood flow to your digestive system. You shift it to the skin. We call that the splanchnic shift. All right? And then when you're running from a mugger, you want to see in the distance. When you're resting, do you want to see in the distance? You want to be able to read. You want to see close. So you dilate your pupils. All right? So to summarize this whole thing, parasympathetic, we call it SLUD, S-L-U-D, or S-L-U-D-D. Not that you have to know it, You know, I mean, it's not mentioned anywhere important except on, your board exams, pharmacology. I'll make sure it's mentioned again in A&P. And for me, it's mentioned. So 4 courses, 5 courses, patho. So the next 5 courses, you don't have to know that because you can get those questions wrong, right? So you better get this right and organized. So the way you visualize this, it's SLUD, secretion, lacrimation, urination, defecation. If you want 2 Ds, digestive system. So when you learn pharmacology, I would write it down because now I'm giving you 2 questions on this. You got it? Okay. So basically, that's your parasympathetic stimulation. So when you're when you're eating food, please tell me what happens to the saliva production. It increases. And if you have a patient that gives you a drug, atropine, that is anti-SLUD, please tell me about the oral effects. Tell me about your saliva production. So if SLUD is secretion, lacrimation, urination, defecation, right? If you have a patient taking a drug that's anti-SLUD, please tell me about the condition of the patient's mouth. Very dry. Anti-SLUD is also if a patient gets head and neck chemotherapy, which is why they have xerostomia, because you've knocked out secretion to the gland. That's why parasympathetic gland here is very, very important. The parotid gland is stimulated by the 9th cranial nerve. That is a good question because it is key to this. The 9th cranial nerve, as you know, is the, what's that? Glossopharyngeal. Okay? It also gets impulses from which? Cranial nerve number 5. All right? Now, the parotid gland is a large gland, so the facial nerve goes through it. Facial nerve does not irritate it, does not affect it, but it goes through it, which means if you have swelling of the parotid gland, you can cause facial pain. Why? Because you press upon, okay, the facial nerve. And that is what a case study, and that is how a case study is handled. You have to relate the whole picture. And that's how I like to ask questions. Because that's really what's on your exams, your board exams. So now the parotid gland drains into the lymph nodes, and blood, really, and it's supplied by the external carotid artery. What does the external carotid artery supply? It supplies predominantly the face. The internal carotid goes up to the circle of Willis and the brain. So we really have to do, that's why that's kind of thing we make you hopefully study that. So here we have something called cyaulography, where we inject a dye and we can see the structure, whether or not there are any blocks. We put in the cannula, we inject, and we can see if there are any blockages here. So here is the location, and you can see how the nerves begin to cross the parotid gland. Here is mumps. You can see the swelling clearly, and that's really what we call the chipmunk cheeks, and that is very painful because we swell the glands. This is the other thing that's also important that I can't emphasize, and that is secretory IgA. IgA is a great antibody. It's one of the 5 antibodies, right? IgG, IgM, IgA, IgD, IgE, right? God made 5 antibodies. Now, secretory IgA undergoes, receptor-mediated endocytosis. So it goes from the lumen and crosses and is secreted in the oral cavity. So it's the primary antibody in the oral cavity, and it's more important than just meeting foreign antigens, okay? Because of this. The reason it's so important is It's called immunoexclusion. What that means is this, is that it not only binds to the foreign compound to get rid of it, very, very important, it prevents viruses and bacteria from binding onto the oral cavity, which means it can't penetrate. It isolates the oral cavity from viruses. And the oral cavity is continuous in terms of epithelium with one weak spot. I know, which one? I got it. So here is and here you can even see a malignancy of the parotid gland. So you palpate it bilaterally. I think you had that. So you start anteriorly, move it backward towards the ear, then inferior to the mandible. All right? So here is where dentists have a problem, is that sometimes if a dentist, for the most part, pierces the gland because it's so extensive, and if they give an injection, one of the problems are they say, well, the patient is not having a sensation. It's not ablating any pain, but the patient now complains about facial pain. Well, when you penetrate the parotid gland, very simply, you can damage the facial nerve. So if you do an inferior alveolar injection, and if you really give it incorrectly, you can cause this facial paralysis. It doesn't affect it. Remember, just passing through is really what we see. Okay? You can have cancer, anything here. You can have patient having unilateral pain, of cancer is one side, or bilateral pain, which is a little bit more rarer. You have the submandibular gland, is an encapsulated gland, both parotid and submandibular is encapsulated. They're covered by a capsule. That's really kind of interesting point. You know where it goes, right? It's the submandibular fossa in the mandible. And then the primary duct here is what we call Wharton's duct. All right, and that goes on either opening on either side of the frenulum, under the tongue. Kind of interesting. It is innervated by the parasympathetic nerves of the seventh cranial nerve. Both the submandibular and sublingual are stimulated by the facial nerve. The difference is the parotid, which is what nerve? Glossopharyngeal. Good question, don't you think so? I think so too, but I don't know if I'll ask it. It's one of the many questions I have. All right, good, see? So here's your exam that goes on. And you can have it has all the ducts, but again, the other thing is that it's majority of saliva. It makes this thing called lysozyme. You heard of lysozyme? It lyses bacterial walls. I think I mentioned that to you. Okay, lots of ducts here. Sublingual gland for us is smallest and diffuse. That means it's non-encapsulated. So if you ask this, a non-encapsulated duct is the sublingual gland. The parotid and submandibular are what? Encapsulated. Okay? It's in the sublingual fossa. Now, the primary duct is Bartholin's duct. They also have Rivinus duct, but for me, the primary duct here is Bartholin's, and it's found really in the same area. It really uses the same opening as the submandibular. Okay? It's also parasympathetic, and it's affected by the facial nerve. Okay? All right, and you know how to do the examination. You use your two fingers. It's right next to the mandibular canine, but it is fairly diffuse, as you can see. It's a mixed gland, about 5%, but it's predominantly mucus for us. Okay? Okay. So xerostomia, or dry mouth, really decreased secretion of saliva. from many, many causes. Once you decrease salivary secretion, you're very prone to infection because the tissues can dry, you have trouble swallowing. Again, certain disease states like Sjogren's syndrome, also very typical in patients undergoing head and neck chemotherapy. All right? What's a short? And then, so what we want to do is stimulate salivary production. You can use, again, I pointed out to you before, you use the sugar-free candies, or you can use artificial saliva, or there's a drug called pilocarpine. And pilocarpine can be used to stimulate salivary gland production. We are also now experimenting with various components of gene therapy. We have minor salivary glands that are located in the labial, the buccal areas, the lingual areas, the soft palate, the posterior part of the hard palate. And also, if you're taking a look at the hard palate, it's always on the lateral portions of the hard palate. You don't have it in the center, or it's really on the most extreme areas of the hard palate. You have monopalatal salivary glands. The ducts, the glands of Van Ebner, are under the circumvallate papillae. Okay, they are exocrine glands. They have ducts that are very short, and all of them are innervated by the seventh cranial nerve, the facial nerve. So every salivary gland is stimulated by the seventh cranial nerve, except the parotid gland, which is innervated by the ninth cranial nerve. There we go. See, kind of easy it is. So you can have all kinds of lesions. You can have stones in there, silith formations that block salivary secretions. So very typically, they're easily removed, unless, of course, you will require surgery. So you can palpate the stone, or you can see it in an x-ray. Here's a picture. This is a rather large stone, all right? So really, ultimately, that if a patient has repeated problems with forming of these stones, you may have to ultimately remove them surgically. But for the most part, they may be able to be manipulated out. Again, please remember that there are a whole range of medications that can come out. So if you're following this, I will tell you, if you printed the next PowerPoint, I did change around a little bit from last night to today. Okay? So I can't help myself. All right? So again, anytime you have xerostomia, you may have drying up of lacrimal glands as well. You got to be very, very careful. Again, people have trouble speaking, and you know, if I didn't have 3 cups of tea before I came here, a Diet Coke and a cup of coffee, I'd be very dry. So again, a patient, as you probably would guess, can have a dry, sticky feeling in their mouth. When you have xerostomia, they may also complain of burning mouth. That would be fairly typical. Again, speaking. Again, you can see cracked lips, and very prone to infection, very prone to sores. So again, here you can see a tongue, and it looks almost like a geographic tongue. All right. Then you have hyperkeratinization. Do you know what that is? You ever heard that? So what is it? When does that occur? Yeah, so it occurs if you can have the damage here if you have exposure. I call it pizza mouth. You know when when you take the pizza burn. So if you continue to do that, don't learn. Or again, people who smoke cigarettes might get this, or cigars, because it's the heat that can cause the damage, not necessarily anything else. So it's we really try to protect ourselves, and easily done biopsies in here. So what is saliva for? As I told you, it's for communication. It's a barrier against noxic stimuli. It's for immunoprotection. It's for washing your mouth. You want to make sure that things that are non-adherent, adherent things are problematical, which is why we want the secretory IgA, so it's easier to wash out the bacteria, easier to get rid of the viruses, and again, forming the salivary pellicle. Again, for saliva, it is odorless for the most part, depending on the foods that you eat. But if you eat garlic, you may have it, not necessarily from the saliva, you may have it ooze out of the pores, some other tissues as well. It could be cloudy. It could be watery. I would demonstrate this. Or you've heard of rope bead? It comes out in strands. Again, very important in terms of this. There are two types of saliva. There is resting and active saliva. So the amount of saliva that you produce in an active state is 10 or 15 times greater than normal. Okay? That's kind of important too. I think I've gone, there we go. I want to make sure I cover it. Okay? Very important in taste. Needless to say. So you make about 1 liter a day, which is an incredible amount. It has the glycoproteins, antibodies. It has to control the pH. So you have bicarbonate, you have phosphate, you have potassium, you have sodium. Essentially, it's this reason. The reason you need bicarbonate and potassium is that prevents the demineralization of teeth. If you lower your bicarbonate levels and lower your potassium levels, you're going to demineralize. You're going to lose bone mineral, okay? You start the digestion of starch. Again, you get your taste. Again, the natural antibiotic, the lysozyme, the secretory IgA. And again, you really need this, especially in children who are having newly erupted teeth. You got to make sure that they have the right amount of calcium, phosphate, sodium in their diet. Elevated potassium levels would tend to demineralize. You got to be very, very careful. Okay, lots of enzymes here. All right, submandibular, lots of the mucins, very, 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 very important. Okay, now, what do we want to do here? I'm going to skip this for a moment. Okay, we'll skip that for a moment. Buffering, pellicle formation, maintains the tooth integrity. This is very, very important. And I tried to emphasize this a minute ago, but again, this is very, very, very important because this allows the teeth to harden. And as you know, as we're going to go over, the enamel is one of the hardest substances of the body, and really depends on the saliva. This is also a key thing, and that is saliva is key in tissue repair. It's important in helping repair your oral tissues. It has growth factors in it that allows a more rapid repair. As a matter of fact, wound repair in the oral cavity is faster than nearly any other part of the body, which is, again, fascinating to me. All right? So we got everything in our saliva. Electrolytes, you got organics, you have ions, you have blood, you have the inflammatory cells that you get out of the sulcus of the tooth, right by the junctional epithelium. You have keratins, you have bacteria, you have every secretion that you can think of. Your digestive secretions, your nasal secretions that all drip, everything appears in your saliva. All right? Now, so here's just the list of everything that you have. So, okay, now a lot of things affect salivary flow. So, thinking about food, smelling food, looking at your LaCroix makes me think, will it increase my salivary flow? And pain, by the way, increases salivary flow. Just seeing if you're alert. And you working in a patient's mouth also does that. So, patient becomes fearful, right? This is, that's your stress reaction that will decrease salivary flow. You decrease salivary flow when you sleep. You decrease it when you need it, which is when your body's fever. Medication's decreasing, and after eating. That also makes sense, right? Because you've done your job of eating. This is before eating, during eating. This is after eating. So you're going to see the differences. Okay. pHs of saliva between 6.0 to 7.9. It's usually around 7 though. It falls during sleep. It rises when you eat, which makes sense. And again, It falls after eating, which is a very significant component of caries formation. So that's something, again, to think about. So, again, we've gone through all of this, so I don't have to go through it again. But again, it's just a repeat. Again, everything that we could can evaluate that we went over is very, very important. So there are two types of saliva, unstimulated and stimulated saliva, okay? This is what you produce constantly, all the time. It is high level of protection. It is primarily the minor glands and your submandibular glands. Unstimulated output will even decrease in the evening when you're asleep. Stimulated output is to protect mastication, protect and swallowing, and now stimulated, although the parotid is 25%, it has a much more important role. Okay, so it's 25% is really elevated when you have stimulated. When you get older, you really don't have many changes. Some people go back and forth on this. Again, neoplasm will decrease flow. Inflammatory diseases, anyone, head, neck irritation, and of course, your diet is very important. But there are certain medications. Now, this one, you can come back to this when you're doing pharm or studying for your boards. What drugs affect salivary flow predominantly? So here's something to keep in mind. Your anticholinergics, which anything that stops acetylcholine. So these are your anti-SLUD. Okay? Your antihistamines render your patient more susceptible to caries formation if they're taking lots of antihistamines, because it cause certain types of antihistamines cause dryness in the mouth. This is also key. And these two. So we'll speak about this. Antidepressants. Any drug, the side effect of nearly any antidepressant is xerostomia. When I teach pharmacology to nurses, I tell the nurses, they don't want to do this. They only think of that, we'll cure the patients. But I tell them that a nurse or hospitalized patients, you have to evaluate oral health care, and you should teach patients proper oral health care. They should call them a hygienist when patients are taking certain medications. So you've got to be aware of the antidepressants and antipsychotic drugs. And then any kind of sedative or hypnotic drugs, like the benzodiazepines, Valium, tricyclic any kind of these drugs. Even some of the drugs that you take prior to oral surgery are sedative and hypnotic agents that can influence and dry up the oral cavity. Patients who are taking antihypertensives, drugs to lower blood pressure, and this one is kind of interesting. On those patients, usually as they get older, who have Parkinson's syndrome, many of the anti-Parkinson's the side effects are anticholinergic. So you have to review good health care with these patients. For the reason, it's not necessarily the disease that's causing it, it's how you treat this. And just for a fun thing, here are all the oral symptoms that you may find on the drugs that your patients will be taking. So the xerostomia, dysphagia, you can see this whole thing, that there are, most drugs have some kind of oral effects, all right? So, kind of fascinating how all of this rolls here, okay? And again, there are certain diseases that you want to be careful of as well. I know a lot of it is Sjogren's syndrome and sarcoidosis, usually of the lungs, but affects, when your patient has sarcoidosis, essentially the primary effect is going to be on parotid glands, which means they're going to have trouble producing enough saliva when they eat. Cystic fibrosis, diabetes, Alzheimer's. Why Alzheimer's? Because they're taking all kinds of drugs to slow down. Okay, Alzheimer's, they have lower amounts of dopamine or acetylcholine, so it's kind of interesting. AIDS, and of course, if you're dehydrated. Nearly every chemotherapy drug alters, not only for head and neck radiation, but patients with leukemia, patients with HIV, patients with nearly anything, you'll have salivary effects. And again, bone marrow transplantation. What's interesting about transplantation, I give a lecture to the residents on transplantation because there are many oral effects. Some on saliva, definitely on the teeth. And again, clearly hormones do have a profound effect as well, okay? All right. We're going to stop at this point, not for the course, so relax. I'm going to now start on oral mucosa. So I'm going to stop this recording and then go on to the next lecture. And we've got, okay? Unless you want to take a quick 5-minute break. 5 minutes? 4 minutes? Okay.